how the profession needs to be in 9–10 years' time is really no different to how we need to be today. But we have to work fundamentally different. And I want to go over really more of a personal view. This is, whilst I am the chair of the Medical Council, the Medical Council has not discussed what the workforce will look like in 2025. We're far more interested in the competence and professionalism of the workforce at any particular point in time. So, but these are based obviously on hopefully an informed background. I've been called a mover and shaker quite recently, actually, Curtis. It was my GP and she was referring to my abdomen. And I asked her if she was going to charge me for that opinion, and she said yes, and we put the fees up last week. So I was very grateful for you to raise that. So the qualities are generic, and fundamentally demonstrable professionalism is what we need from all healthcare workers, particularly from doctors. Professionalism is an overarching term that covers many things. It's competence, it's how we behave, it's our ethos, etc. So we need to be competent and capable. We do need to be appropriately distributed. That may not be how we are currently geographically distributed, because how the patient accesses us is going to be far more important than how we access the patient. It needs to be sustainable, and Health Workforce NZ have an extremely elegant model that's recently been developed where you can put in any number of variables for any number of medical specialties. You can change retirement patterns, you can change volume of trainees, and you can see what that means for the future. And it does, the profession does need to be tech savvy. So I think the challenge for us, and what I want to work through today, is really how do we achieve demonstrable professionalism in the environment we're likely to find ourselves in. Now, the environment we find ourselves in involves having to predict the future. If you sit out at night and glance at the stars, of course you're seeing the past, because that light left those stars many, many years ago. So you've actually got to look into the blackness, which is a little disappointing, but hopefully we can inform the blackness by considering some of these things. We do need to consider what's happening with our population. We must be responsive to the needs of that population, so the expectations not only of the public but also our employers, those who fund us, those who regulate us, need to be taken into account. Technology, new treatments. Is it cheaper to fund Keytruda or fund sunscreen? We need to debate this and come up with a logical approach to the future. Is bariatric surgery really the treatment of choice for morbid obesity in our population? I can assure you in South Auckland it is not. It's great for the 0.1% who get it though. The changing profession, the climate in which we live and work, and hopefully that'll allow us to come to how the workforce should be designed. This is from Statistics New Zealand from 2014. There's various versions of this graph about, but essentially the over 65s are growing. This will come as no surprise. The in workforce ages, you know, that sort of late 20s through to 65 is fairly static, if not reducing. So unless we're all earning more, the tax base is staying fairly stable or decreasing. That goes to Hein's comment about the underfunding of healthcare, which I think we have to assume will continue. It's best to plan for that eventuality than think we're going to be in a utopian environment where the government can pour billions in. And of course we have the growing older population. I don't think we're going to do away with paediatricians despite the fall in the 0 to 14s, Hein, but you know, you never know. Yeah, I do want to get rid of orthopaedics, but that's only because they take the theatres too often. Again, various versions of this graph, and there's the DHBs have a version of this looking at DHB population changes, but not surprisingly, somewhat of an urban drift, and some centres, particularly some of our smaller, more remote areas, losing population. That's an enormous problem under population-based funding. And of course, it may alter where the specialist workforce wants to work. As a parent, one of your key things is looking at where you want to bring up your kids, what sort of education they're going to be able to get locally. Are you going to have to send them off to boarding school to get the sort of education you want them to have? All of these issues are important with regional population changes. And Hein touched on this. This is from the Medical Council Workforce Survey. Around 12,500 doctors' data is in here. And Statistics New Zealand divide the country into urban, secondary urban and rural with those population numbers per square kilometre. Not surprisingly, a lot of younger doctors tend to be in the more urban environment, and that's where obviously you come out of med school, PGY 1 and 2 in DHBs. The bigger metropolitan DHBs need more of you, so that's not surprising. Then of course there's a lot of vocational training goes on, which tends to focus people still in relatively large centres. But if we look at that problem of the green line, which is rural, it emphasises that tidal wave, if you like, of older rural practitioners heading towards retirement. And you'll note the age bands at the bottom. So we do have a looming retirement crisis in particularly rural New Zealand in healthcare. What about expectations? I was on the Capacity and Capability Review last year, and the overwhelming message was that the population of New Zealand would like to live longer, healthier lives and be as independent as possible. And that's pretty reasonable. I think that's what I'd like to do. That's what my almost 91-year-old father has managed to do. The public deserve better information, and we do need to move on from informed consent to informed choice. Informed consent is me very nicely documenting what I told someone. Informed choice is someone taking that information and making the right decision for them in their circumstances. Most people want care relatively close to where they live, but I think we do have an obligation as a profession to make it clear that quality needs to trump convenience if there are conditions or treatments or expertise that cannot be delivered everywhere for a population of just over 4 million. And equity is crucial. We had a treaty signed over 175 years ago. We have disgraceful inequity, not just for Māori, but we have a duty, I believe, and certainly this is the Medical Council's view, that the profession needs to work with the public, because the public have a right to expect basically the same access and the same outcome, irrespective of who they are and where they live. That comes with a lot of challenges for us as a profession, because we don't own the budget. One of the biggest barriers to equity of access is funding, and so we have to look at how that's going to be solved. But equity is a public expectation, and I'd go so far as to say a basic human right. What about the Medical Council? Well, we want far more demonstrable competence. If I bowled up to the Beehive and the Minister said, just reassure me, you know, Annette King's on my back in question time this afternoon, just reassure me everyone's competent out there, I'd have to be in the difficult position of having to lie to the Minister, because I cannot say that, because we don't measure it. So the annual practising certificate that the Medical Council will issue to all your young students when you graduate is not a tax receipt. That is a byproduct of the bit of paper, because it's got our receipt on it. It should be tangible evidence that we believe this doctor is competent to practice. And this goes to the heart of what ASMS is working on, the Council of Medical Colleges, employers and the Medical Council working on, which is around what in New Zealand we refer to as recertification. Overseas it's often called revalidation, but it's really that tangible assessment of how we are going. It's a mix of our knowledge. We're very good at recording knowledge at the moment. It's called CPD, Continuing Professional Development. We write down we went to a conference, or we went to that talk, or we read that journal article. But it does not assess our performance, and it doesn't involve peer feedback. So younger members of the audience, all of you with hair, are entering a time where this will become just part of your daily routine. Very straightforward. It's very easy and it's very sensible, and it certainly means that the public we can maintain the confidence of the public that the profession is competent for the role we need them to do. That's why performance is really important in this, because your learning should be relevant to what you are doing. I'm a general surgeon. My elective subspecialty area is colorectal. The only breast disease I treat is breast abscesses on acutes. And even then it's really just making sure my registrar's drained the pus. So why on earth should I get CPD credit for going to a nice conference in Europe on breast cancer? Yes, it's in the general surgical curriculum, hence I can put it down for my CPD, but it really says nothing about my competence. It does nothing to improve my professionalism in terms of caring for patients that come under my care. Professionalism oversees all of this. Really important. And the Medical Association has made a very public, very good stand on the need for the profession to be as professional as possible. And I'd just like to acknowledge Stephen Child's leadership on that. Again, the regulator expects equity of outcome, and we obviously expect and require safe and effective practice. What about the funder? Well, they've got a whole bunch of different drivers. When Pete Hodson was Minister of Health, he came to Middlemore and he wanted to talk to the head of general surgery, so I was rolled up. And he said, boy, you guys give me a lot of grief. And I was saying, crikey, Dick, you know, we've done quite well, actually. And he said, yeah, you guys are 3% of my budget. And I said, what do you mean, us? And he said, elective surgery, 3% of vote health. You are the other 97% of my political grief. And that's because we're all measured on things that can be counted. And it's easy to count elective outputs. So we will still be in an environment in 10 years' time where we are publicly reported on things that can be counted. The funder, of course, wants high quality, but that's harder to count, and it often takes longer. My quality in elective surgery is probably 5-year local recurrence rates in rectal cancer, not a 5-minute count of how many cases I did, which is how we're measured at the moment. And of course, it needs to be in budget, and it's going to need to be within a proportionally smaller budget. Now, what the funder is definitely going to want, and the government has started working on this at the moment already, is greater intersectorial work. That's a fancy way of saying that health is not just the responsibility of the Ministry of Health. It involves social development, it involves education, it involves police. In South Auckland, there are roughly 1,000 nights of mental health care provided in the cells at the Manukau police station, because the DHB is not resourced from a mental health point of view to care for those individuals. They haven't been locked up because they're criminals. They've been contained because they're a danger to themselves or possibly others. That is, I believe, unacceptable. And so we need this intersectorial work to go ahead and be successful. One of the biggest problems, though, is when you introduce more than one ministry, you, of course, have more than one minister, and they're all fighting with Bill English for the same slice of the budget. So this is not easy, but it is important work. And I think it's fair to say we will see far more questions coming to us from social development about why is this person unable to work from a health point of view? What can social development do about helping this person back to health and employment? So expect to be counted, but it's great to see so many young doctors and students in the audience, because you guys are the future. It is never too early to get involved in wanting to address and be part of the solution to these sort of questions. If we leave it to others, we will be screwed. That is an absolute certainty. So self-regulation is a wonderful privilege, and we need to make sure that we don't abuse that privilege by neglecting to get involved. So it's great to see you here. Now, are these sort of expectations reasonable? Timely and convenient access to information, diagnostics and treatment sounds like it should be reasonable, but there are a few questions. Can we deliver these in all parts of the country? Well, maybe the question is, can we deliver these to a person who lives anywhere in the country? DHB boundary is currently a problem to delivering that question, to answering that question, as opposed to a system that works together properly to address the needs of each person in the country. Can we afford all the treatments we need? The answer is no, so we need a much better debate with the public about what we can afford, what is our healthcare system trying to deliver. Are there treatments we don't have? Absolutely. You know, someone in the States actually went through several years of new information appearing in peer-reviewed medical journals and worked out that all information, you know, from the most minute cellular stuff to population studies, is doubling every 6 to 8 weeks. So there will be new treatments and new information. And do we have the right information to make decisions? I would suggest we absolutely do not. We function in an information vacuum. It is unacceptable that I cannot, at the push of a button, tell a patient of 85 in South Auckland with bowel cancer and diabetes what is his chance of not getting back to his own home if I take his cancer out. What is his chance of ending up in residential care? We should have that information because that goes to informed choice for that patient as opposed to informed consent about the risks of the procedure. So we need to up the information, and technology obviously has a major role to play here. It gives us immediacy of information. And again, I think we have to be far better involved over the next decade to deliver to you, the doctors of 2025, the type of information that will make a difference to how you practice and how your patients are cared for. Clearly, remote consultations occur now. They will occur a lot more. What is the value of dragging someone in 25, 30 kilometres to see me for 5 minutes if I could have done that down, say, a Skype consultation or whatever? The trick for all of us, and certainly for the regulator, is the safe environment. And we have to be front and centre on this as clinicians, because not having to build more outpatient buildings on a DHB chunk of land saves an awful lot of money. So the DHBs are rightly interested in how we can provide more consultations without having to invest in real estate. So the danger is there'll be an overreaction and they'll think no one needs to see the doctor face to face. And we do need better data for decision making, for patients, for doctors, and for the funders, because there may be things we are doing that we frankly should not be doing if we knew the outcomes properly. So disinvestment should not be seen as a bad thing, it should actually be seen as a legitimate function of a well-functioning health system so that we can deliver the right care at the right time to the right people. There are, however, questions about technology. We're all interested in patient portals and the patient record. But should patients have a right to withhold information? That point needs a real big debate. Not all patients want their GP to know they've been to a psychiatrist. Not all patients want their GP to know they've had their STD treated last week up at the sexual health clinic. They may have actually said at either of those environments, please don't write to my GP. That is the patient's right. But if we don't know they're on a particular medication for treatment, what is the value of actually having half the story instantly available? So a really tough question that frankly needs a lot of debate with the public. What is the value of owning information and having information? What is the extent of the information we have? Is it relevant for a 75-year-old to still have their paediatric information available? Who knows? May well be. Of course, the one thing you can't do down the internet is a physical exam. So we have to sort out what do we do if we're, say, doing a first specialist assessment by Skype and we think someone needs to actually feel their abdomen. Well, we do, frankly, what we do now. My registrar rings me up at 2 in the morning and tells me someone has a rigid abdomen. My first thought is, do I trust this dude or is he an idiot? Usually I trust them because our registrars are very good. And then I'll make some informed decisions because I've delegated that physical examination to my registrar. So it's the same thing. We might be delegating the physical exam to the general practitioner. But, you know, those are issues that we all have to get our head around. And it certainly has implications for how we train students and do vocational training, because you're going to have to get used to this sort of style of practice. So the didactic bedside teaching is not the only way we're going to have to teach so that we can do effective consultations. And of course, radiology being an easy example, an international workforce. It is very attractive to think that a radiologist at 2 in the afternoon is more awake to report a CT scan than at 2 in the morning. That means, why can't someone in the UK be reporting the 2 AM scan done here? Now that raises real big questions for patient safety, for the regulator, not to mention our own workforce. So we need to ensure that we have standards to assess the competence of people who are based overseas, and also what do we do if concerns are raised. And the Medical Council's consulting with the profession at the moment on some of these issues around telehealth. But these are real issues that need to be resolved. If anyone decided to stick a robot in New Zealand, there is no technological barrier today to having a surgeon sitting somewhere overseas doing an operation via that robot, because it is an internet connection. So these are real issues that will become more germane as we head towards the middle of next decade. What about new treatments? Well, genetic advances, obviously massive, not just for cancer, but the way drugs are delivered in pharmacology for various diseases, actually twiddling fundamentally with the genes which are occurring overseas. Stem cells, we're not talking about taking fetal stem cells, talking about taking your own stem cells. It is possible to now grow organs. We've all seen the mouse with its own ear regrafted on, or whatever the hell it was. So it is not outside the realm of possibility that we will literally be organ farming. Now, maybe not in 10 years, but I would say within 20 years, Curtis's job, if someone needs a transplant of their kidney, may be made easier by somehow triggering that patient's stem cells to make a new one, which of course makes transplantation so much simpler. That's perhaps a bit extreme, but it's just to give you a flavour of the fact that there are real changes that are possible theoretically today, certainly in the laboratory today, that will come into mainstream practice. On the downside, unless there's a major breakthrough in dementia treatment, boy oh boy, are we facing a problem as we have this ageing population, not to mention all the heavy tackles in rugby. Now, changes to the profession, excuse me, attitudes to hours work, perhaps versus lifestyle is wrong, it should be and lifestyle. I actually see my job as quite a lifestyle choice. I work in a major hospital, major unit, don't do private, 1 weekend in 14, life's pretty sweet. Not everyone would see it that way. We have currently about 1/3 of the vocational workforce are women, 50% of vocational trainees are women, and obviously around 55%, I think it is, of medical students, possibly higher? 61% of medical students. Now, I don't think any changes in technology is going to change the fact that the ladies are having the babies and the boys aren't. So we are going to face, not surprisingly, more doctors having families during those early years of their training or their vocational career. But these do have impacts on rosters and services. The last 5 consultant appointments in my department have been women. We have successfully raised 5 children out of that. In fact, we found it pretty easy, but we're a large department. If you're in a smaller department, smaller hospital, 1 in 3 roster, and someone's having 6 months off or 12 months off maternity leave, that's a major issue. So we have to think about these things now. And I think great credit to both Otago and Auckland that the number of Maori medical number of students who identify themselves as Maori is now proportional with that of the population. Pacific still need to grow a bit, but we are making huge strides. And the Medical Council believes that part of cultural competence are the vocational colleges grabbing the hearts and minds of those graduates and supporting them through vocational training and supporting them after they finish, because some of the cultural requirements on some doctors, because of their ethnicity or their cultural identity, are far higher than they are on some others. And we need to address that so that we don't lose the overall value of those people. This graph shows the gender balance of specialists, females in red, males in blue. You can see the orthopods down on the bottom there. Proud moment. Had to put them on the slide, that's why it's so big. But you can see that, and this represents the fact that about 1/3 of the vocational specialties are populated by women. Changes when we look at training. We're now at 50%, it'll probably go up. Our specialty, in fact, briefly got to 50%, but it was because quite a few, then it came down again because we had quite a few guys out doing PhDs who came back into the mix. It's rejigged the mathematics. But you can see that there are increasing numbers of women entering vocational training. And it's still, if we've got 61% of the medical schools are women, 50% of the vocational trainees, you can see that that number of vocational trainees who are women will probably increase a bit further as we go along, because the ethos that pretty well everyone in health wants is people to engage in vocational training. So we, certainly Medical Council, very keen on vocational training, health workforce very keen on vocational training. This is the age and gender distribution graph though. And this is the sort of thing that Professor Gorman's algorithm can change in an instant to show you what will happen. So the red line is the profession as a whole, the green is the blokes, the blue is the women. And you can see that there is quite a difference at the south end of that graph, left-hand side of that graph, which is representative of the increasing volume of women going through medical school. At the other end, we see currently women tending to retire earlier than some of the blokes. Now, why? Lots of theories. Spouse might be 2 or 3 years older, hits retirement age, stops. The grandkids come along. And certainly a number of my colleagues who are female have said, yeah, I'm going to stop because, you know, daughter's having a second child and I missed out on the first one, blah, blah, blah. It's just human nature. But that graph, of course, is going to impact on how we deliver care if that trend was to continue, given we have more women coming through the profession. Hours worked graph, this is self-assessment by the 12,500 doctors who filled in the workforce survey, but you can see, broadly speaking, the bar graph are the hours worked, average hours worked, red women, blue men. The lines are the head count. So what that probably shows us in terms of hours worked might be an FTE issue. Women may have a little bit more time off during the week than the guys, perhaps bringing up the kids, etc., etc. Don't know, not massive differences in hours, but a small difference. What is dramatic, though, again, emphasising that the head count falls off dramatically as we get older. So what can we predict from that if the current trends were maintained? That work hours graph would probably stay static for about the next decade. Then around that 2025 mark, we'd probably start to see a steeper drop-off in the number of doctors over the age of 65 who are working as the proportion of women entering that age group takes over from the men. That greater number of young graduates then entering vocational training and the vocational workforce, if the work patterns per week stays the same, also opens some interesting questions about that sort of middle zone, that 15, 20 year period of consultant practice. Is that going to be enough to radically change the number of SMOs we need to staff some services? And that's an important question because that's going to influence health workforces' funding decisions, and it's also potentially going to have an impact on training capability and capacity. Having said all that, that graph of how many doctors over 65 are working has actually changed over the last 15, 20 years, with more doctors working past the age of 65. That raises itself some interesting questions because there is very solid neuroscience data about our brain function. This is not to say that you're burned out, no use after 65. There are many doctors who can and many who will and should maintain a very safe, very worthwhile and high level of contribution in their practice after the age of 65. But we need to debate now what it means for future planning. When I was started as a consultant around the age of 35, I recovered pretty easily if I was up all night. Now in my early to mid-50s, I'm really stuffed for a couple of days. Now at 65, I don't want to be on an acute roster after hours. The way our department's constructed, which is fortunate because of our size, is that I can actually do acutes only during the day and still teach, train, oversee, perform a worthwhile task. But the complexity of task is probably the kicker. Our brain function for simple or well-learned repetitive things, even at might be a fairly complex thing, such as taking out a bit of bowel or doing a heart operation or doing a bronchoscopy, etc., Monday to Friday during daylight hours in an elective environment is maintained. But if at 3 in the morning someone comes in who happens to be a haemophiliac Jehovah's Witness who's been crunched in a trauma, the 65 or the 70-year-old expert seeing that patient in resus may not think rapidly enough through the variables to get that patient better. So we need to start debating that now, and I think we need to reach, as a profession and with our employers, a consensus on how we're going to address that. If I was to come off the acute roster, the first phone call would be probably from my wife saying, "What are you doing? The bank just phoned," because your pay goes way down. So we need to address value in ways other than just hours worked. Now the climate's changing and we are getting warmer. The microclimate of Northland will support dengue fever right now if a mosquito bothers to come this far south. So, you know, we've had weird tropical fruit flies all through parts of Auckland. It is not outside the realms of possibility we will have dengue fever set up shop. Probably for the last 20 years, it's been essential in counties to be able to think TB might be a diagnosis because of our strong Pacific movement in particular. But we will see other diseases due to migration. We are entering an era, or we've probably long ago entered it, where antibiotic resistance is an absolute clear and present danger to healthcare. And there will be a need, as I know already happens, but the universities and the colleges will be continually having to refresh their curricula to make sure that the way we're training undergraduates and training vocational aspirants is actually fit for the environment, types of diseases, the way we need to work in 2025. So how will we look? I don't think we need a complete sex change. We need an intellectual shift. That is Bruce Jenner and Caitlyn Jenner. Led to a fascinating debate last night whether, you know, Caitlyn could go into the Olympics, and if so, in the women's or the men's event. I'm not joking, it actually led to quite an intellectual debate, admittedly one that my kids dominated. So delivery of care. Delivery of care needs to change. It is a nonsense, in my opinion, to think that the doctor still needs to see every patient. And I'm uncertain if we have general practitioners in the audience, but I really think this is a major impediment to community care in general practice, is that there is an overarching view amongst most general practitioners they still need to see everyone. The focus has already started to shift, but ideally does need to shift further to ideally preventing illness, but certainly minimising the acute exacerbation. So we will see far more of hospital-based secondary specialists taking their skill set out into the community, particularly in the medical specialties, respiratory, endocrine, aged care as obvious examples. At the moment, to address the budget or the budget shortfalls, we're asked to restrict access. A number of times I've been asked by general manager upwards if I can turn the tap off a little bit for elective surgery. That mindset must change. We need to restrict deterioration to the point of needing expensive hospital-based care as opposed to restricting access. An easy example to use, probably not an easy one to achieve though, would be entry onto dialysis. So type 2 diabetes leading to ultimately renal failure requiring dialysis. We need to really put our emphasis into ideally preventing that diabetes, or at least making sure it is managed very well so Dr. Walker runs out of business. And of course, we like to think we practice evidence-based medicine. Where there's an absence of evidence, we certainly need to practice informed medicine. Better informed than we do now, which goes back to the data issue. I got into med school on the back of my English mark in the days where you could get in from bursary, so John Donne was a poet, no man is an island, or no doctor is an island. And the idea that we can practice in isolation needs to stop. Technology is changing. Multidisciplinary approach to care is here to stay, as it should be, and far more care needs to be delivered in the community. Again, not saying that has to be all by general practice. It involves getting rid of some of those barriers that certainly exist between primary and secondary care. We will see the growth in scope of practice of other professional groups. We've got examples of that with nurse practitioners. There will no doubt be others. Pharmacists, I'll make another comment on shortly, but we really need to use their skills more to address some of the needs, particularly of the elderly population, the polypharmacy, etc. And this, of course, is going to require some change in the mindset that we as doctors have. No better time to start than grabbing the hearts and minds of the undergraduates. So the doctor really in 2025, in fact they should be doing this now, should see the complex stuff and we should oversee the more mundane. Easy example, there is no benefit in my house surgeon doing 49 out of 50 discharge summaries. There is benefit in number 50 because that's the person who came in that we didn't know had diabetes, didn't know had renal failure, didn't know had uncontrolled hypertension. That's where doctor-to-doctor correspondence is essential. The other 49, frankly, are a waste of that person's time. We need to see, for those who go into vocational practice in the community, a breakdown of this isolated practice to practice, because the economies of scale dictate that better integration across practices in the same geographical location is sensible. Very good example in Horowhenua of nurse practitioner in respiratory disease working across 5 general practices, each individually not capable of sustaining that employee. Between the 5 of them they can sustain 30% reduction in acute respiratory admissions over the last 3 years for that cohort of patients. Clinical pharmacy needs to be more attractive than selling cosmetics. What on earth are we training pharmacists for if they're mainly dispensing? We need to train them for their clinical knowledge. And when you look at the ACC statistics on falls in the elderly, when you look at some of the data that DHBs or hospitals do have about medication side effects, etc., in the elderly, there is a crucial need to get clinical pharmacists far more engaged over the next decade in the care of patients in the community. Special interests and expertise is important, and it should ideally dictate that the patient sees the right patient at the same time. That will include in general practice. There will be vocational trained general practices as they are now, general practitioners just as there are now, who are really enthusiastic and very, very good at paediatric stuff. Someone else will be in the same practice, perhaps very good at the geriatric stuff. Again, the mindset of the public has to realise that perhaps seeing a different doctor in the same practice is actually an advance in their care. So we have a duty to somehow get that across to the public. Secondary and tertiary, our boundaries are an impediment to the right thing. I think at this stage there's no appetite to get rid of DHBs, but we do need to, I think, as a profession, keep pushing that funding is currently and will continue to be a barrier to doing the right thing. There are some wonderful things called inter-district flows. I'd advise any of you who haven't graduated yet to avoid any meeting you're invited to about inter-district flows. It will simply make you angry. Because on one hand you'll have a DHB saying, yeah, we can do that for you, and on the other you'll have the finance guy from the other DHB saying, for God's sake, don't send the work up the road, it costs us a fortune. Choosing Wisely is a campaign that started in the NHS around making sure that our decisions for each patient are right. And this is going back to having the right information for the right patient to make the right choice. But we do need to make sure we permeate that through all aspects of care, particularly secondary and tertiary from the point of view of some of the interventions we currently do because they're damn expensive. Team-based care needs to really be team-based care. It will address a multitude of issues. So I've touched on some of these: the polypharmacy in the elderly, the care of chronic diseases, respiratory and diabetes, particularly trying to prevent that acute exacerbation. Prehabilitation before an elective operation will get better results from that elective operation, just as rehabilitation will. And I think we will continue to see a growth in a call for secondary care, tertiary care doctors, particularly interventionalists, to have their, to justify their outcomes. There was a big debate last year about mortality rates for surgeons. It was utter nonsense. Paediatric ENT surgeon will hardly ever have a death. Doesn't reassure anyone that that paediatric ENT surgeon is competent. But it is right that the public should know what they get from their paediatric ORL service. And the service has to be held accountable for the individual outliers if there are any. So I'm not particularly a fan of the word transparency, because to be transparent you need either a very bright light or a very thin subject matter. But there will be more publication of outcomes. And we should not fear that, but we must get involved and on the front foot of it to make sure the context is right. Training at all levels needs to prepare us for those new diseases, new treatments, new ways of working. And I think we will, for instance, need to train on how to perform virtual consultations. That will be a skill that we currently don't have. Counties, we have 110 dialects and languages that we employ interpreters for. We have apparently used about another 100 ad hoc, so 200 dialects and languages in South Auckland. And there's a move to use remote interpreting services. You know, that's quite a step for us, let alone then going to a virtual consultation. Now, generalist skills will remain vital, and we have to keep working with the colleges who are mainly binational, us in Australia, to make sure that we do not forget the strong generalist background. I am proudly a general surgeon who happens to electively do mainly large bowel surgery. If we don't have a generalist approach, we cannot provide acute care. There is no point having a department full of subspecialist breast surgeons, because they can't be safe in the acute abdomen. No use to me on an acute roster as a head of department. So the problem at the moment is that we employ based often on subspecialty interests and needs. And that, of course, is a little bidding war going on between 20 DHBs. So I think by 2025, I would hope that we have a more nationally defined approach to what we truly need as a subspecialist, i.e. an expert in really only doing that, versus how are we training to maintain excellence in the subspecialty areas of each vocation, whilst overarchingly having a generalist approach to allow safe delivery of acutes. We must train our own specialists. This is a very interesting graph to me because it shows what happens. The yellowish line is New Zealand graduates, the blue line IMGs in New Zealand. What happens in the years from year 0, which is when they obtain vocational registration here. And you can see we have about a 15% drop-off or 12% drop-off. That's not unexpected. That goes up a little bit again because some people are registered as vocational fellows and then head off overseas for a couple of years of fellowship or something, come back. But generally about 9 out of 10 who get FR something after their name, if they're a New Zealand graduate, end up practicing in New Zealand. Drops off for the IMG, so we must work with Health Workforce to keep training our own, as opposed to what some people, I would say universally outside this environment, believe is a far cheaper model, which is to import others. We should not be a net importer of specialists, we should be training our own. The IMG workforce, and there's definition issues with IMG, by the way, that are quite, will have skewed this a little bit, but basically the trend as you see it does not support stopping high quality vocational training for New Zealand graduates. So how will we make these changes? I think we need to examine how and where we train. Almost all colleges end training in the big smoke. What on earth does that do for the ability of Gisborne or Blenheim to attract someone? Why are we not tailoring training more to the needs of the community by somehow coming up with a magic formula to pick the right trainee who might want a job somewhere other than in metropolitan Auckland? I think the ministry and the government need to look at some of the funding barriers to quality teamwork, and I would hope by 2025 that will occur. And we certainly need much better data to reflect the needs of those groups in particular. I challenge us to recognise, I think the challenge is to recognise these issues and to start acting now. If we keep doing what we're doing, we'll get what we got. And it is just not sustainable. We've already heard from Hein that the money is already short by over $1 billion. That is just going to grow. We have an ageing population, a changing workforce. We need much better data, and we need the data that you and I need. Obviously, our colleagues in administration in the ministry and the hospitals need some of their information. At the moment, we pretty well only have their information. We have to accept that the gender makeup of the profession has changed. We need to adjust for that. We do definitely need to change how we deliver our care. We need to embrace technology, but make sure it is what we need to deliver care to our patients, not something that some executive from IBM might think we want. We need to be telling the tech companies what we need rather than having them trying to sell us a product. We need to maintain the generalist foundation, and I think we need far better national planning. So in conclusion, it should all be about quality. It's possibly the first time I've mentioned quality, but it should all be about quality care. And I think in 2025, quality care is achievable. The quality now is superb. The challenge is to maintain it and to improve any areas where it isn't. But to do that and to be in such a high quality system in a decade's time, the profession needs to be visibly competent, because that goes to the core of trust with the public. Need to be capable of functioning within team-based environments in whatever setting we're in. We need to be able to reflect on our outcomes better than we do now, and we need to change when those outcomes aren't good enough. And we need to encourage a rewarding clinical practice, but at the same time we need to acknowledge other craft groups can also be capable of delivering high quality care, which goes back to working in a team environment. So that's my presentation. It is gazing into the future with a few predictions and a few extrapolations, but I think the future of healthcare is very bright as long as we maintain our drive and enthusiasm as a profession to be very, very much front and centre, debating and influencing the decisions, because ultimately the money will determine a lot of our outcomes, and we have to influence those who are deciding on how to fund and construct our systems. Thanks very much.